In the same area, we're going to ask Dr. Lindhold to talk to us about the results of a randomized clinical trial comparing propatin PTFE stretch grafts to standard PTFE stretch grafts.
Thank you, and first of all, thanks to Dr. Wyeth for inviting me. Chairman, ladies and gentlemen, on behalf of the Scandinavian Propatin trialists, I'm very proud to present to you the first-year results of this randomized multicenter clinical controlled trial testing heparin-bonded PTEF grafts. Here are our disclosures. Cohort reports of the luminal heparin-bonded Propatin grafts shows promising patency rates. However, such results is only level 2B evidence. They aren't randomized, there aren't any controls. So our aim was to test whether Propatin grafts improve primary and secondary patency in a randomized multicenter setup. We included all planned femoral-popliteal and femoral crossover bypasses due to functional or critical chronic ischemia. We aimed for a 90% power trial and calculated that we would need 484 participants for that. However, we ended up having included almost 100 more patients than calculated. A few were excluded due to errors or changes of the planned operations, and a few were lost for follow-up. But 546 had sufficient one-year follow-up, and of these, almost 20% lost their primary patency. Randomization were performed one-to-one, stratified by center, and a mandatory duplex scanning was required at the final one-year follow-up examination. Concerning primary patency, not much happened the first 3 months, but then a difference started, ended with a significant reduction in the risk of occlusion by 36% by Propatin. Looking back, we realized that it was a beauty spot in our design that we did not stratify the randomization for type of bypass and perhaps also critical ischemia. So we decided to do one adjustment analysis for that, and the significant finding remained unchanged and significant after this adjustment. Concerning secondary patency, Propatin grafts tended to perform better also in the first 3 months, ending at 1 year with a significant reduction in the risk of occlusion by 40% in the Propatin group. And this significant finding remained unchanged and significant after adjustment for type of bypass and critical ischemia. We then decided to do subgroup analyses concerning cases with critical ischemia and type of bypass, well knowing that power is lost and the chances for type 2 error increases. However, the benefit of the Propatin grafts was amplified in the cases with critical ischemia by halving the risk of losing primary patency. And this significant risk reduction remained unchanged after adjustment for type of bypass. Concerning crossovers, Propatin decreased the risk of losing primary patency in crossovers by only 8% in general, but in critical ischemia, it was more than 1/3. However, it wasn't significant. Concerning FEMPOPs, the one-year primary patency was as high as 80% regardless of present critical ischemia or not. In general, Propatin significantly halved the risk of losing primary patency, and in critical ischemia it was as high as 2/3. So in conclusion, ladies and gentlemen, Propatin kept its promises from the prospective studies. It significantly increases primary and secondary patency by 36% and 40% respectively. And it seems that the worse the clinical situation is, the more efficient the propertin graft becomes. By significantly reducing the risk of occlusion by half in critical ischemia, and by 2/3 when a febrile popliteal bypass is used in critical ischemia. Finally, I would like to thank all those who had assisted us in conducting this trial, and Gore for sponsoring an annual meeting to keep up our motivation and involvement. Thank you very much for your attention.